So the next part of the mini-series on CSF is we're just going to talk through how to take a lumbar sample. So we're just going to demonstrate that now on a cat that we've got here. First things we just like to talk through is the positioning. So sometimes depending on whether you're left or right-handed might affect whether you'd prefer the cat or dog in left or right lateral recumbency. Similar to when we took the cisternal CSF, we like the patient to be positioned at the very edge of the table, on a nice flat table, making sure the brakes are on, and the patient's always under general anaesthesia. And then next, we'll just demonstrate sort of positioning. When we're positioning, what we want to do is just try and open up that lower lumbar space as much as possible. So what we try and do is really flex the back legs, really pushing up on the abdominal cavity, and that's how we're going to position before we now proceed to take the sample. So for lumbar CSF, the landmarks that I'm going to try and feel, firstly are the wings of the ilium, which I can palpate as these bony prominences here. And then on the midline, I try and then feel the first really palpable dorsal spinous process, which I can feel just here, which is typically the dorsal spinous process of L6. And then you decide which site you want to go in at, depending on the size of the patient, and particularly if you've done some imaging, you can actually see where the spinal cord finishes. So for this cat, I can palpate L6. I'm then going to just see if I can palpate L7, I think is just in here. So what I'll try and do is use my spinal needle with the stylet still in situ and go basically off the front of the dorsal spinous process that I can palpate. So if I use this one here, so basically I'm going to insert my needle so that I'm trying to actually hit bone, so I know exactly where I am in terms of on midline. And then what I then very gently and gradually do is just advance the needle and keep sort of walking it off the bone. You can see the tail twitch there. Hopefully that means we might be in the canal, but let's see. So I gently remove the stylet and then just watch carefully for any CSF production. Am I getting a bit of CSF? So just watch, it takes a while to come up the hub of the needle. So I think I'm getting a really small volume of CSF in the hub. I don't know if you can see from where you are. Annoyingly, there's a tiny bit of blood contamination, which frustratingly is really common for these lumbar samples. Often you can hit the venous sinus with your needle. But what I'll do is I'll just let that fill gently and see if that's enough to obtain a sample. Generally, cisternally, if you get blood contamination, you can quite easily just reposition and get a clean sample. In lumbar, generally, once you're blood contaminated, frustratingly, that's probably as good as it's going to be. If you go in at another site or location, you tend to have a similar level of blood contamination. So what we do is just let it sit, and then often the blood might sediment out in the hub of the needle, which can give you a slightly cleaner sample. So now we just have to wait for the CSF to appear. As tempting as it is to try and move or wiggle the needle, I've generally learnt the hard way. It's actually better just to keep the needle in situ, basically, to let the CSF flow. Sometimes people describe there are other things you can try and do to increase the CSF flow. For example, you can do things like occlude the jugular veins because they basically reduce the venous return, so you can increase your CSF. But generally for the lumbar ones, I find that doesn't tend to make a difference. So as frustrating as it is, patience really is a virtue. I'm just going to wait for the fluid to come. So eventually, and the rate of CSF flow can be really variable, I just let it gradually fill the hub of the needle and let it just passively come out so I can collect my sample. Hopefully shortly we'll see a nice drip of CSF. The benefit as well of not trying to wiggle or move the needle, as you can probably see from the side, the little bit of blood contamination that we do have has sedimented out quite nicely. So I'm hoping that the spinal fluid that's actually about to come out of this needle will be a bit clearer and might be a bit more accurate in terms of our cell count. There's a bit of blood contamination, but it's settled out quite well, so this actually looks quite clear. So this cat's been a bit slow in terms of giving us CSF, so we've only really got a small volume of sample here. In an ideal world, what I would then do is actually use what's in the chamber of the needle. So spinal needles typically contain roughly about 0.2 mil of CSF. However, because this cat's got some blood contamination, if I was to just upend and use all the sample in this needle, I will introduce all that blood and have a contaminated sample. So something else we can do is try and use a needle and syringe and actually siphon off the CSF in the hub of the needle. Thank you. So what we can try and do is just gently remove the CSF that's in the hub of our needle without disturbing the blood clot. So what I'll do is I'll come in here and just gently introduce the needle and then just gradually aspirate, trying to stay away from that blood clot, just to get the most of the sample that I can that's sort of clear and not disturb with blood, like that. So it's not much of a sample, but I've got roughly another 0.1 of a mil there just from doing that. And then once we're finished, I just very gradually and gently remove the spinal needle and we're all done.